The next part of the session is what can we all do for our patients. I think one thing we can all agree on is that medical management for our patients can be suboptimal, which can lead to disease progression, reduced durability of any surgical radiological interventions that our patients might have, and ultimately worse outcomes. So we're very pleased to have Marc with us. Marc Bailey is an associate professor in vascular medicine at the University of Leeds and previously a BHF Intermediate Clinical Research Fellow. He has a particular interest in vascular medicine in patients with vascular surgical disease, ranging from identifying new drug targets, repurposing drug trials, and implementation of existing medical medicines in vascular surgery patients who are one of the most underserved population. So Marc is going to be talking to us about better medical treatment for vascular patients now and in the future. Thank you.
Thank you very much, and thanks for the invitation to talk in the Circulation Foundation session. I should disclose I was once funded by the Circulation Foundation. So, we all know why we're here. As I've said already once today, peripheral arterial disease is common. For this talk, my focus is much more on the generalized cardiovascular risk. And what I want us all to focus on is not only is it common, it represents 1/4 of the global disease burden for all atherosclerotic cardiovascular disease. As I said earlier this morning, yes, there is a small risk of progression to limb-threatening events, but these patients that we look after have high, if not the highest risk of major adverse cardiovascular events, which means heart attack and stroke. If you go into the CLTI cohort, that risk is extreme. It is worse survival than most cancers. I'm not really talking about AAAs in this presentation, but the same story is true. We've heard today already about their relatively low contemporary rupture rates, but they also sit with a 3% annual MACE rate, which is around 100 times higher than the rupture rate of a very small aneurysm. In terms of patient priorities in this space, particularly number 10 in the James Lint Alliance research priority setting exercise was very much focused on risk, and point 8 on slowing down disease progression. So I'm going to talk to you today about the existing medical therapies for this, with my hat on particularly around our failure of implementation across the sphere, really. So starting with antithrombotic therapy, aspirin has been around since the dawn of time. It's an extract from white willow bark. It was used by knights of the Round Table to rub on each other when they'd been impaled by a lance. It was then made into a tablet by Bayer, famous for being a German pharmaceutical company who beat Manchester City last night, which I enjoy as a Man United fan. It was marketed as a fever cure and then fell into somewhat of disrepute after the war when German chemical companies weren't very popular. It sprung up again in the 1970s when its antithrombotic properties were noticed, and the sort of landmark trial was ISIS-2, which showed that if you gave patients who just had a heart attack aspirin, they died less from another one. Like in lots of things with vascular surgery, we sort of implemented that same thinking in our patients. Now, interestingly, if you look at a meta-analysis, and this one admittedly is quite old, but there are many similar, there's a lot of variability around the impact of aspirin on patients with peripheral arterial disease on their outcomes in terms of MACE rates. And on average, there's actually not much in terms of positive benefit. There's a subtle positive benefit. Clopidogrel, based on the Capri study from 1996, seems to have a much stronger effect in our vascular patients, and this is where the NICE guideline recommendation comes from. However, there is certainly concern with this, particularly in Europe, because of the high incidence of clopidogrel resistance genes, particularly in Northern European populations. You can see in this example study, in patients undergoing vascular or coronary intervention, there was over a 50% incidence of this. We've tried various things over the years. We've stolen from our colleagues in cardiology. We've tried ticagrelor. We've tried dual antiplatelet therapy. We've tried warfarinizing people. None of those things have any significant impact in our PAD patients. So really, for a long time, we had clopidogrel. Next to come along was this idea of dual factor inhibition. So you've got your antiplatelets dealing with the platelet aggregation and activation, but the idea was to add in something that would limit the coagulation sort of thrombin pathway, and this is the COMPASS regime, the mixture of aspirin and low-dose rivaroxaban. Now we're talking about really big trials. This one has almost 30,000 people. You can see the survival curve at the bottom with a hazard ratio of 0.76. There's a very nice tool by the German Vascular Society for risk stratifying PAD patients for use of this regime. and it was studied specifically in PAD in the Voyager PAD study. This was looking at 6,500 patients with PAD who had had revascularization. All patients in the study were given aspirin. They were then randomized to low-dose rivaroxaban or placebo, and use of clopidogrel was left to the treating clinician. And you can see here the survival curve for the composite outcome measure of your standard cardiovascular death, MI stroke, but also including limb events and major amputation. You can see here a hazard ratio of 0.85, so a clearly effective strategy in high-risk vascular patients. If you substratify the study based on the patients non-randomized to clopidogrel or not to clopidogrel, you can see there isn't a major difference between outcome. Now, we heard a little bit earlier that there is a trial Clarity that will give clarity to this question. No laughs. Disappointing. Graham, who's in the audience somewhere, did do a statistical comparison of the data from the original Capri study and the data from Voyager PAD. And this suggests that the impact is actually quite similar between these two antithrombotic strategies, but I suppose time will tell. The next important element is appropriate treatment of cholesterol. I think the field in general has moved away from fire and forget statin strategy towards delivery of lower LDL cholesterols. And this graph shows the relationship between the magnitude of lifetime exposure to LDL cholesterol and event rate through various different study types. It's summarized at the top by the statement from the cholesterol treatment trialists that for every 1.0 millimole per liter you reduce someone's LDL cholesterol, they have 22.3% less events every year. Now, guidelines in this space are quite confusing. Our own British guidelines are pretty useless. They just say get the LDL below 2. Our European colleagues have these much clearer ESC guidelines that suggest lower LDL thresholds based on risk. If you look at the very dark red group, the very high risk group, that includes all patients with clinical or imaging evidence of atherosclerotic cardiovascular disease, including PAD. That is all of our patients. So I would certainly recommend that we try and get the LDLs down to 1.4. What tools have we got to do this? So, brief science lesson. The LDL receptor was discovered in 1985 when that discovery was awarded the Nobel Prize. And traditionally, we've sought to reduce cholesterol within the liver to upregulate LDL receptors on the liver surface to suck more LDL from the bloodstream into the liver to be excreted through bile. We can do that with statins or bempedoic acid, which reduce LDL production in the liver, or we can do it with ezetimibe that reduces cholesterol absorption from the gut. We now have newer agents, particularly PCSK9 inhibitors. These compounds block PCSK9, which normally serves to internalize the LDL receptor. Statins have been around for many years now. They are quantified based on their ability to lower LDL cholesterol. So you see a lot in the guidelines, this term high-intensity statins. These are shown in green. This is any statin that will give you above a 40% reduction in your LDL cholesterol. When I talk about maximal high-intensity statin, we're talking about using atorvastatin and rosuvastatin at their top dose to give as much lipid lowering as they can. To briefly review some of the classical trials in this space, the most important is probably the MRC BHF-funded heart protection study. Again, huge trial, 20,000 people with all manner of atherosclerotic disease. And this randomized patients to simvastatin versus placebo and shows a very clear approximately 20 to 25% reduction in events in the statin group. Prove It was focused on acute coronary syndrome, but this is looking at low versus high-intensity statin therapy, showing that high-intensity statin therapy is more effective, and you can see the differences in the LDL-C on screen. And then finally, the Improve It trial, which is looking at adding ezetimibe to statin therapy, which shows small but significant additional improvements with combination therapy. Moving on to PCSK9, this was discovered in 2003. It has a strong genetic basis for cardiovascular disease, and there's been a large effort to drug this target. We don't have an oral therapy yet, but we do have injectable therapy. There are monoclonal antibodies, which were licensed in 2016, and an siRNA licensed in 2021. If we focus on the monoclonal antibodies, the Fourier trial was one of these trials, looking at 27,500 people with all manner of atherosclerotic cardiovascular disease. You can see here these were patients already on standard therapy. The LDLs now drop to 0.78 in the treatment group, and there is a 20% relative risk reduction in cardiovascular death MI and stroke. The reason I wanted to show you this trial is they did a PAD subgroup analysis. So if you pull out the 3,500 PAD patients in the study, you can see at the Kaplan-Meier curve at the top, the darker, more solid lines are the PAD patients. Blue is placebo, red is treatment. The other dotted lines are everyone else. You can see our patients have more of the events, they have a lower number needed to treat, i.e. they benefit more from this treatment, and still with the treatment, they have more events than anyone else in the study. And this really shows us the immense high risk that our patients have. At the bottom is limb outcomes, and you can see there is a very strong trend, although the study wasn't powered for it, suggesting a prevention of major adverse limb events with the PCSK9 inhibitor treatment. How are we doing across the patch with delivering these therapies? So Santorini was looking at all cardiovascular disease across Europe. The answer is not particularly well. The average LDL-C was 2.1. You can see in the middle, the UK came third worst. Generally, the trend was lack of use of top-dose treatments, under-appreciation and classification of cardiovascular risk by doctors. In vascular surgery, there's very little data. Thanos, who spoke earlier, led a Verne study just before COVID that showed we are doing similarly badly with average LDL-Cs of 2.7, around half above the NICE target at the time, and only 11% on a maximal dose statin. So this is suggesting we're not using optimally what we've got. How can we try and make this better? Well, in Leeds, we've made a big effort over the last 10 years to move away from, GP to do secondary prevention, please, to giving some specific instruction. So what we would recommend is you start with a baseline LDL cholesterol. We're very bad at doing these. Commence immediately on a top dose of a high-intensity statin without careful up titration, because it just doesn't happen. Recheck the LDL after 3 months, and then either you've got to your target, which is good, you've got ridiculously high LDL of 3.5 or more, you can give monoclonal PCSK9 inhibitors, and that's normally through secondary care pathways that will vary by region. If the LDL is 2.6 or above, you can give them inclisiran, and GPs can do that. They get paid to do it if you ask them nicely. If the LDL is above 1.4, but below that inclisiran target, this is where you can use ezetimibe as a cheap additional therapy. And what I'm showing you here is how this can change what patients are prescribed. These are graphs showing green is better for higher intensity statins, red is nothing. On the left-hand side of the screen, your right, you've got the traditional fire and forget approach of ask the GP to just sort secondary prevention. On the right is our more prescribed stepwise approach, and you can see you do get more patients on higher intensity statins, you do get fewer patients who are prescribed nothing, although it's far from perfect, and you do see a requisite reduction in LDL cholesterol. The dotted line that says Europe is the ESC target, so you can see whilst on average the LDLs do not look too bad, we have a huge number of patients who don't meet their targets, and repeat sampling was poor at only about 50%. What's coming down the tracks next? Well, we're now thinking about residual cardiovascular risk over and above antiplatelet and LDL lowering. Omega-3 fatty acids are licensed. So we have data from Eskimos for a very long time that a high fish diet with lots of omega-3 is protective from cardiovascular events. Telling people to eat more fish, buying omega-3 over the counter doesn't really work, but icosapent ethyl is a super concentrated omega-3 fatty acid, equivalent to about 3 cans of tuna per dosing, and gives you an additional approximately 25% relative risk reduction in cardiovascular events. It doesn't touch LDL, so it's an additional additive pathway, and it's licensed by NICE. And the final thing coming down the tracks is thinking about inflammation. So the LODOCO-2 trial in heart disease shows successful impact of colchicine with very impressive hazard ratios, and LEADER-PAD is open for recruitment in multiple sites around the UK to address this in PAD. We've developed this infographic for GPs, which makes them think in this way about residual cardiovascular risk in different elements across all cardiovascular disease to try and drive implementation. So to summarize, I would say PAD means high, if not highest, cardiovascular risk, and we need to be mindful of this. We can't do all the prescribing. There's too many patients and not enough of us, but I think we should and can lead by example. And I've summarized what I'd suggest for antithrombotic and lipid lowering. It is worth always thinking, have we checked the LDL cholesterol? If not, it's a very easy thing to do when we interact with them in clinic or on the ward, and using this simple pathway to up-titrate therapy. Please do help recruit to the medical trials that have just started in this space. I think that will really help us understand what is best. I want to leave you with a cartoon about whose job is it. You can read it whilst I'm talking. Fundamentally, I think it's everyone's job. We have to work with our colleagues in primary care and in pharmacy to try and get this delivered. And we're not alone. The cardiologists have exactly the same problem, and they're working in a disease that everyone who goes through medical school understands, I think, much more than our own. The final thing I've put on screen is a QR code. This is from our research fellow, Ryan Lalou, who's doing a survey on what you're all using in different scenarios for antithrombosis. And if you want to scan it and complete it whilst you're here, please do. Otherwise, we'll send out an email, and I'm happy to take questions with 1 second to spare. Thank you, Neeraj.
Thank you very much, Mark. Any questions from the audience? I have a question. How have you found because one of my questions was whose responsibility do you think it is in a way? And you've answered that by saying it's both our responsibilities, but any advice you would give in terms of trying to implement or trying to lead by example, and also the follow-up, if we're supposed to be checking the bloods in 3 months' time, we don't often see those.
It's a very good question. So unlike lots of our medical specialty colleagues, we don't follow a lot of these people up. So the data I showed you from Leeds, these are people who we saw once and discharged back to the GP. So we give stepwise specific instruction and find that seems to be followed better than just saying, please follow guidelines. I think where we have the chance to influence properly is the patients with CLTI. Because we see them lots of times, they stay under our care. So certainly when we're following them up, thinking about graph surveillance, that's an opportunity to check all of their residual risk, see if we can add anything else in, repeat blood tests. And we're increasingly thinking that when they're on the ward for revascularization, getting our pharmacy colleagues to think about this and advise us, remind us, is also a potential option. And I think certainly the licensing for inclisiran means that is a very easy win that you could deliver whilst patients are on the ward.
Professor.
Great talk, Mark. When I'm doing the FRCS, I give an 8 to candidates who educate me. You'd have got a 9.
Thanks.
Fantastic. You say we should concentrate on the critical ischemics, but I kind of get the impression we might have missed the boat there. Is there any way of identifying the high-risk claudicant who will, be the 1 or 2% that does develop critical ischemia, or be the 5% a year that has a heart attack, that we can really go to town on and try and prevent that heart attack or that limb loss?
I think it's a really interesting question. I don't think we have that answer. But I think, whilst I say we can focus on the CLTI, I think they're the people we see a lot. But I think as a society, it's all of PAD and all other atherosclerotic disease. And I think it's a very, very difficult dial to shift. And I think understanding how we influence the wider education of the medical workforce in this space is the challenge. Whenever I speak to GPs or to community pharmacists, they're really, really interested. They never even thought about PAD. Most of them, never even crossed their mind. But it's very low impact, person by person. So I think we need to think how we influence much wider. The sort of thing Neeraj was talking about before. And I think that's where the Circulation Foundation has that opportunity to help get that at a very high, probably governmental level.
Mark, we do a lot of difficult interventions, and what you've shown is a stepwise progression down to get your LDL less than 1. Shouldn't those patients on the ward just be getting a PCSK9 inhibitor irrespective of what their LDL-C is?
I think it's an excellent question, and I think the only way we can make that happen is to do the trial that makes the new guidelines. So at the moment, we're limited by the indications led from the trials that have been done. But I think that's exactly what we should be doing.